Are you ready to dive in? So now that our mind is thoroughly blown by Sayer, thank you for the fantastic talk. We're going to get really practical. Now, I know in this room, there may not be a ton of physicians. How many practitioners of any type are here? Raise your hand. Awesome. Because this is super practical clinical data. For those of you who are patients or general lay persons, it's still going to be interesting, I promise. And what I want to do is, James asked me to present cases, and I thought, okay, 20 minutes, that's like one case. Well, I squeezed in two, so you get a freebie. And one thing that I think is real important is I'm going to share with you how these two cases can be thought of a little differently. Okay. So here's my contact. Feel free to connect with me at any point. And I want to invite you, before I jump in, I do a newsletter every 2 months for just practitioners only for functional medicine docs. And all it is the best research that I've been reading, and I just want to share it with you. So it's free. You're welcome to sign up on my website. Just go to jillcarnahan.com under the About tab, and for practitioners. And there's tons of free resources there, and then my free newsletter. Okay, so case number one. These are real patients. This one is a 17-year-old male with Crohn's disease diagnosed a year earlier. So he came to see me. And just background history, as we know, the gut microbiome starts in the beginning of life. He was a C-section baby. He's been his early life in the NICU and many antibiotics. So as you can tell already, we know that the microbiome of an infant is dramatically affected by C-section versus vaginally born infants, and also by breastfed versus bottle-fed. And in addition, of course, in the NICU, a lot of times they receive prophylactic antibiotics. So he started off life with a little bit of a disadvantage because of that. There's some studies that show after a C-section, the baby can never completely regain its microbiome. So as we give even one course of antibiotics, or as we know there's a reason for C-sections, they save lives, so I'm not against them, but those elective ones that revolve around the doctor's golf schedule, we need to really think about that. So Zantac, also first 3 months of life, and that's a proton pump inhibitor, been shown to increase the risk of SIBO, which is small intestinal bacterial overgrowth. And he also had frequent childhood ear infections and many courses of antibiotics. So for the past 5 years, he was off and on, had diarrhea, and this was before his diagnosis. He had anal fissures, hemorrhoids, heartburn, and abdominal pain. Finally got bad enough, he saw a gastroenterologist and was diagnosed. The scope showed classic lesions of Crohn's disease, so he had this diagnosis of Crohn's. And this was the summer before he saw me in clinic, and he and his mom did some research, and they found a Lane-Gottschall's specific carbohydrate diet, which I use a lot of different diets for patients, but this is one of my favorites that has a very good success rate with inflammatory bowel disease. So they did that on their own, and he actually became almost symptom-free with just the diet changes. It was pretty impressive, and that was him and his mom on his own. Mom, he's a 17-year-old high school kid, so mom's cooking all the meals for him and everything. And then, I saw him a couple months after the ski accident. He was skiing, and he hit his head. So why do I mention that? The reason, and this is again a thing in this case that I think is really important to understand, traumatic brain injury dramatically affects the gut. It affects motility, it affects the microbiome, and who would have thought that a head injury could cause a relapse of Crohn's disease? But in this patient's case, I think it was absolutely critical piece of what happened, because suddenly, right after that, he presented with everything was back, the bleeding, the diarrhea, the weight loss, the abdominal pain. He didn't want to go on Humira. How many of us functional docs have heard that one? Now, I'll tell you my opinion on that is there are some cases that are so severe they need immune modulating drugs to get them stable. They're in a life-threatening situation. So if the patient decides with their parents or family to go on a drug like that, I have no problem because I can still look for root cause. And we know with functional medicine, looking for root cause and adjusting the microbiome actually takes some time. And some of these patients don't have time. So please don't let it be that I'm against those drugs, but certainly if we can find the root cause before they have to go on them, that would be the best case scenario. So he had gone back after his head injury on this specific carbohydrate diet, but this time it hadn't resolved his symptoms. So just think, I won't make you say any answers out loud, but and all of you out there in a virtual world, think about what would you do, what would you order, how would you treat this patient? So this was my plan at the initial visit. I gave him a few basic things that I know: multivitamin, vitamin D is essential for gut health. Vitamin A could have been on there as well, as those two work synergistically to heal an intestinal permeable lining. Essential fatty acids are also essential for healing inflammatory mediated gut immune dysfunction. And curcumin is one of my favorite anti-inflammatory herbs, so I frequently use that at high doses if the patient can tolerate it in Crohn's and colitis. Ginger is an anti-nausea agent, and some of the ginger extracts work profoundly well for abdominal pain and nausea. Typically, I think of that in the upper gut, using that. And glutamine powder, we know, is the number one fuel source for the enterocytes. So you're giving those cells that need to heal fuel. Electrolytes, because of the diarrhea, and he was losing lots of fluids, and high-dose probiotics. He was given by his gastroenterologist Lomotil, Zofran PRN, which is antiemetic, and then prednisone. And of course, prednisone short-term just throws a wet blanket on the immune system. So basically, this was not a solution, a great Band-Aid, though, at the time, and it actually gave him some relief. He continued with the SCD diet, and I always recommend patients in a flare of Crohn's and colitis have lots of heated and well-cooked foods, so they're not eating anything raw, basically making that digestion as easy as possible for the patient. And I had him avoid some of the top allergens, of course. I did some testing. You can see there what I ordered. So what were the results? Okay. So how many of you have seen fecal calprotectin as a marker for inflammatory bowel disease? That's pretty classic nowadays. In fact, most of your gastroenterologists, even if they aren't functional medicine trained, will test for that. But you know some other things here, and I'm going to go into each of those. So calprotectin is a marker that can be highly correlated to differentiate irritable bowel syndrome, your run-of-the-mill kind of irritable bowel that doesn't come from an inflammatory source, from the inflammatory bowel like Crohn's or colitis. And the specificity in patients is very, very high. So you can actually use this test to rule out someone who maybe doesn't need a scope. So again, if you have someone who has complaints, abdominal pain, bloating, gas, and you do this test, if you have a normal calprotectin, you can basically say with about 99% certainty that that patient does not have Crohn's or colitis and avoid a scope. However, in this patient, as expected, it was high. He's in a flare. And then calprotectin, we talked about, this is what it looks like. Now, the cutoffs for that, above 50 is high, but above 150 is really high. So 174 is extremely high. He's in a significant flare. And then the pancreatic elastase is a great marker. It's independent of pancreatic enzymes, so if the patient is taking enzymes, it's still accurate. It's a stool marker. And less than 200 is significant pancreatic insufficiency. So this patient was not digesting fats in his bowel at all. The significance of that is if you have problems with breaking down proteins or breaking down fats, those foods basically go undigested into the duodenum and feed the commensals. This often leads to SIBO, or small intestinal bacterial overgrowth, or issues with the commensal bacteria. And at the end of this case, I'm going to tell you why that's really important. We did a culture, and his stool is positive for Klebsiella. You can see it 4+ there. Now, interestingly enough, and this is the sensitivity specificity for drug and herbal treatments. Now, interesting, Klebsiella can be a commensal. Now, by commensal, what I mean is things that normally reside in the gut and don't cause harm. But one of the main points of this case that I wanted to bring up to you is that commensals can trigger an immune response that, if left unchecked, can lead to autoimmunity and Crohn's and colitis. So these aren't always pathogens that we're dealing with. Sometimes we're dealing with commensals in excess, and it's all about the balance. So when you see a Crohn's and colitis patient, my job is to teach them, okay, with autoimmune disease, we know from Dr. Vasano there's 3 things, always. Genetic predisposition. You don't get the disease unless you have a predisposition handed down from our parents, as we learned from Sayer. And then second, an environmental trigger. Now, my job as a functional medicine expert is to look for triggers. So I tell them this. I say, I'm your personal detective, and I'm going to look for triggers that caused your disease. Now, if possible that we can find those and reverse those, you may go on and have a healthy life without issues at all. This is an organic acid test, another test I use to check the gut microbiome, and these are bacterial markers, and you can see one of them is elevated. And I did want to ensure that there was no fungal dysbiosis, so you can see the D-arabinitol is negative there. So you just had the bacteria. So even though I don't like antibiotics, in this case we gave him Cipro and metronidazole for 10 days. and you'll see it really turned him around. His prednisone we just weaned, and we gave him pancreatic enzymes. We added I mentioned the vitamin A with the D. Those are synergistic and should be given together in a 5-to-1 ratio. Zinc, adrenal support. He was extremely tired, as you could imagine. And then we followed the prescription with berberine. Berberine is a fantastic herbal antibiotic. So I really like to use that in high dose at 5 grams a day for difficult intestinal dysbiosis. And often just a 10-day course of antibiotics. In this case, another alternative would have been just to treat with berberine. But he was so sick, I thought, let's go for the quick fix and get him turned around. And in this case, it actually worked very effectively. Saccharomyces boulardii was given to protect because antibiotics won't hurt that. It's a strain of yeast that will protect during the antibiotic course. It's actually a probiotic yeast. So he finished that. Symptom update at 4 months, no diarrhea, no abdominal pain, off all steroids, and he continued his basic regimen. And he's a theater major in high school, did a show, and has been doing fantastic ever since. So yes, thank you, that was good. Here's the takeaway that I want to just encourage you to think about. Inflammatory bowel disease can be caused by dysregulation of the immune response to commensal organisms. So like I said, these may be normal residents in the gut bacteria, in the gut microbiome, and they may be causing an immune response. And basically, as they stimulate the effector T cells, this causes this inflammatory, unstoppable response. Now, the other thing I didn't mention, if any of you know me, you already know this, but 15 years ago, before I ever got into functional medicine, I had Crohn's disease, the diagnosis. Today, I have 0 symptoms. In fact, I almost don't relate to that diagnosis. So I'm one of those people who has actually healed myself through functional medicine. Okay, now just a bit about, this is going to get a little deep, but I think it's important. Basically, microbiota regulates the immune system. And why this is important is because if you start to have imbalances in the gut microbiome in a genetically susceptible individual, you are going to trigger the T cells in the immune system, especially Th17. That will cause increase in cytokines and lead to autoimmune disease. And it may be Crohn's, which is in the gut, but it could also be rheumatoid arthritis, multiple sclerosis, Hashimoto's thyroiditis, and many other autoimmune diseases outside the gut. And I'm a simple person. I love simple pictures. So here it is in a really simple way. You see in this picture, you basically have all the green Treg cells. Treg cells are good guys. They're like the policemen in the gut and in the immune system. And they're saying, hey guys, calm down, don't overreact. So you see in this case, someone is more susceptible to infection because the Treg cells are saying, hey, don't fight too much. Don't put out too much action. So yes, they could be more susceptible to cold or flu or infection of some type, but they're also going to be less susceptible to autoimmunity. So when you have autoimmune disease, Tregs are your friends. And we can now actually measure these through the blood. This is the opposite. I told you I love pictures, and this is just a flip-flop. You see all those pathogens on the gut lining? Those guys are triggering the Th17 response, which you see in the purple cells down below. So that excess of Th17 is a potent, and you're going to hear this theme in the second case I present as well. Th17 will drive autoimmune disease. So again, if someone has upregulated Th17, you have to find the trigger. If you eliminate the trigger, you can often eliminate the autoimmune disease altogether. So pretty impressive. And just to summarize, these commensal organisms can be triggers to Th17 and Treg. And you want to keep a balance. You want to make sure that patient's gut microbiome is in balance. The mucosal immune system, which lines the gut, or SIGA, is one of either tolerance or of this upregulation of T cells. And this at the core is where these things start to happen. Activation of Tregs inhibit the mucosal immune response, and they're also dependent on IL-10. And why do I mention this? Well, now we can all get 23andMe and all kinds of genetic SNP testing, and many patients have genetic SNPs in IL-10. And that's profound because IL-10 is another policeman that controls this. And this is just a complicated diagram that kind of shows you the different parts. The top is Th17, the bottom is Treg, and then right and left are Th1 and 2. And the importance is balance. All of these have a role, so that none of them are bad, but any of them in dominance or too much is going to lead to disease. All right, case 2. So case number 2, 31-year-old female with lupus presents with chronic constipation, reflux, and abdominal pain. She has frequent migraine headaches, insomnia, depression, and anxiety. She craves sweets. Now, why do I mention that? I often ask patients, do you crave sweet or do you crave salt? Salt cravings, not always, but can be significant for adrenal dysfunction or endocrine dysfunction, dysregulation of the electrolytes in the body. Sweet cravings are usually coming from the gut. Did you know that your gut microbiome controls your cravings? So you can blame it on your gut next time you have a midnight snack. This patient also had bipolar depression, narcolepsy. So I also mentioned that because gut and brain. I could do a whole 2 hours on gut and brain and the connection. It's very profound. She has migraine headaches, insomnia, IBS-C, which is a label. Doesn't tell us root cause. Now, I use that label because it gets well covered when we submit it for reimbursement, right? But it doesn't really tell us why. So IBS-C is irritable bowel syndrome, constipation predominant. She's married with 2 children. Okay, so this was her stool profile, just a piece of it to kind of make the case concise. Candida present. And this is sensitivity and specificity. So the reason I brought up this case is because there's an old paradigm where we say, oh, you have fungal dysbiosis, you have Candida in the gut. And while that is important to identify, because treatment may be required, the one takeaway that I want to leave you all with is the question you need to next ask is why? And the reason for that is Candida is opportunistic. We all are colonized by yeast. Yeast in balance is not a bad thing. But what I'm going to share with you about how yeast can be a potent trigger of Th17, the important thing is when you see a patient with this, there's a reason. She's either immunocompromised, she's got a terrible diet, there's reasons, and I'll share with you exactly some of the list of those reasons. But what you want to ask yourself when you see yeast in the gut is not just what drug should I use or what herb should I use, but you should say, why does this patient have overgrowth of yeast in the gut? Because as significant as it is to treat, and patients do get better, more significant is to go to root cause, which is functional medicine, and find out why that patient has that dysbiosis. So these are tests I wanted to show you because I showed you a stool profile in this case, but it's very important. Yeast can be difficult to find, and it's not often in the colon. It's actually more likely to be in the small bowel. If you go to PubMed and Google SIFO, which maybe you haven't heard of yet, small intestinal fungal overgrowth, there's a plethora of articles on how important this is and how it actually can be in the small bowel, right along with SIBO. So if you're treating patients with small intestinal bacterial overgrowth, I always, as part of my practice, want to make sure they don't also have fungal overgrowth because as you can imagine, if you're treating with heavy-duty antibiotics or antibiotic herbs, you can actually flare the yeast. And these two things in an immunocompromised or person in a compromised state are going to often coexist. The other thing you can do is organic acids. This is a urinary test for markers of yeast. Now, this will detect it anywhere in the body. And then you can do serum labs. I frequently do Candida, IgA, IgG, and IgM. So you see if there's an immune response to Candida. And I like to do all three because I find that this is a tricky diagnosis to make, and I want to have all the data possible. This just shows that basically Candida can live in their normal state, these little yeast buds, without causing any harm at all. But when they're stressed, when there's environmental factors that trigger, when there's threats to their environment, they often turn into the hyphal form and invade, and they can become pretty nasty. They can colonize vaginal for women. They can colonize urinary tract for men or women. They can colonize the gut, of course, sinuses, esophagus, mouth, all of these places. And I think going back to my question, do you crave sweets? That's one of the things I do clinically to find out if a patient is doing well because I'm treating them for fungal dysbiosis or SIBO, and I ask them, are you craving sweets? And they look at me and say, no, not really, not anymore. Then I know I'm successful because that craving comes from the gut dysbiosis. So if you're a sweet craver, check your gut. Okay, IL-17, our friend, I told you about this. This is really important because fungal pathogens in an immunocompromised state are one of the most potent triggers for IL-17. And do you remember what I told you about IL-17? It's one of the most potent triggers of autoimmune disease. So this all connects. This article talked about the IL-17 pathway regulates antifungal immunity. They're connected. So the body wants to naturally fight the fungal issues, and it upregulates IL-17 to do that. But the downside is that IL-17, as I showed you with those diagrams, is going to drive autoimmune disease. Celiac disease. How many of you know that the gene sequence with Candida is very homologous to gluten? And how many of you know that there are many, many people who are born, they don't have celiac disease, they might have the HLA-DQ2 or DQ8 homozygous genetics, so they're prone, they have the predisposition to get that. But when they get a yeast overgrowth or a fungal dysbiosis in the gut, they all of a sudden become true celiac or even non-celiac gluten sensitivity. The reason is this yeast will cross-react on those HLAs. This is how I tell my patients. HLAs are a little Pac-Man that line your gut. So what they are is they are your genetic code of the samplers that line your immune system. And these little Pac-Man are always sampling and taking a bite of the things you throw down the tube. And when these samplers see in someone who has the HLA-DQ2 or DQ8 genotype, when they see gluten, they think it's a foreign invader. And they send out the troops of the whole immune system, so this immune system is in a state of alarm. But that HLA may go the first 10, 15, 20, 55 years is the average age of diagnosis of celiac disease. So they may go many, many, many years before they actually become gluten intolerant or true celiacs. And this is one of the pathogens that is known to trigger that into activation. So that's important too, because you have someone who comes up back with yeast in organic acid testing or stool testing, you want to check if they're sensitive to gluten. My protocol for patients is almost 100% of my patients are gluten-free because I treat the complex and they often are sensitive. Symptoms of fungal dysbiosis would be fatigue, poor memory, insomnia, anxiety, mood swings, muscle pain. So how common are all of these things, right? Risk factors, this is where I said you have to ask the why. And the importance of that is you have to say, what is causing this overgrowth or this problematic yeast? And again, immunocompromise could be one. Extremes of age, so the very young will often get a thrush. Your babies, some of you have gone through that. High stress, broad spectrum antibiotics, diabetes, because they're going to be running a higher blood sugar, and of course yeast loves sugar. Corticosteroid treatment, so that would be prednisone, things that would suppress the immune system, or any of the medicines that suppress immunity. There's many of them out there now being used to treat autoimmune disease. Now, how ironic is that we use immunosuppressives to treat an autoimmune disease that is driven by Th17, that could be driven by Candida or other yeast fungal species, and those are going to be increased with immunosuppression. Conventional medicine sometimes doesn't make a lot of sense, does it? And pregnancy can be an issue too because those hormones can flare. Now, one thing I didn't list on here, but in our post-flood boulder, mold can be a potent trigger, perhaps one of the most potent trigger, mold exposure to not only fungal dysbiosis, but a decreased immune system. So mold is by nature immunosuppressive. Where do you think we got some of our drugs, like penicillin and some of those? Okay, so treatments you can use, antimicrobials like fluconazole, itraconazole, nystatin. My favorites are herbal combinations because they treat this combined dysbiosis and they don't really affect the gut microbiome to as an extent as the antibiotics and drugs. And diet. And I love this because it talked about coconut oil fed mice was much better than soybean oil or any other oils for colonization of Candida albicans. So you can have your patients just use coconut oil as a treatment as well. Okay, this next one is one of my favorite slides. Did you know you can have autobrewery syndrome? NPR wrote this article and I loved it. Who knew you can brew in your gut? But it's true. I'm not lying. I encourage you. This is, I think, a 20-minute podcast. Great, great. And so many docs have no idea of the pathogenicity of some of the Saccharomyces species. So we use them to make beer. But if we have a problem in our gut of overgrowth, these can actually brew alcohol in our gut. And I'm going to prove it. I've got the chemistry. So first of all, these are some of the main fermenters. So if patients have overgrowth of Enterococcus, Streptococcus, Prevotella, and yes, yeast, as you can imagine. And often they'll feel, there was a great case on like Dateline or one of the shows that talked about this patient that kept getting pulled over for drunk driving. Can you imagine? He's like, I haven't been drinking. And he kept getting pulled over, was in the emergency room, and then he had this bicycle accident. And the cop was like, what's going on? You're drunk. Made him walk a straight line. He is just going all over the place. He's like, no, I haven't been drinking. Finally, they tested him. And he had this going on. He had Saccharomyces species in the gut. They were brewing. Here's the diagram. Yeast metabolism. You can clearly see right in the middle, there's our friend ethanol. So yeast and then those microbes I mentioned actually can brew alcohol in the gut. And like I said, I wanted to bring you another take-home that I think even many functional doctors aren't aware of. Saccharomyces, we know it as Saccharomyces boulardii. We use it as a treatment, right? I used it in the first patient. But there's other species of Saccharomyces in imbalance that can be major pathogens. So don't think of when you get Saccharomyces back on one of the profiles that you do, don't be like, oh, that's just a benign thing, I give that in the clinic. This could be the worst pathogen you've dealt with. It's extremely hard to eradicate. Think about this. When we order those IBD, inflammatory bowel disease panels, do you know what we're testing? Anti-Saccharomyces antibodies. How does that connect with this? And that's a predictive factor in general gastroenterology for Crohn's and colitis. So this is the case study I was telling you about. Fascinating. Google it, read it if you get a chance. It's just amazing because it's very, very real. Now, you'll find those patients who, the other day, now this is unproven, but I'm going to mention it anyway because I think it's so interesting. You do organic urinary acids. You're supposed to freeze the urine, send it to the lab. This patient couldn't get her urine to freeze. So my mind, I'm like, okay, what doesn't freeze? Alcohol. And guess what? I think we're right. I have yet to prove it because the tests are waiting to come back, but I'm thinking you have those patients who get rejected by the lab because their urine didn't freeze. Check for yeast or these brewers in the gut. Pretty cool. I just wanted to share with you, these are on top of one another, a couple of slides, many, many, many articles out there on Saccharomyces and the pathogenicity. So don't assume Saccharomyces is a good guy. It could be very problematic. And this, multiple sclerosis, one of the epidemics of our time, and I think one of the most difficult, challenging cases to treat, although I've had several successful cases. It's widely believed that environmental factors, including fungal infections, contribute. Now, do I think that that's the only thing that causes MS? No. But the gut is definitely connected. And as I mentioned before, environmental factors, genetic predisposition, and the microbiome combine to create autoimmunity. So you're always looking at those things in your autoimmune patients. Okay, now take a deep breath, and I have something fun to show you. Okay, and my last slide or two. So this is my grandbaby. So yay! And I wanted to show you because isn't that face like classic for, yeah, I got a present for you, Mom, Grandma. And the reason I brought it up is because I want to talk about poop. So promise of poop. The future of the microbiome is learning more and learning how we can actually manipulate versus just kill, right? So the future is transplant. It's manipulating the organisms by feeding them good things like probiotics and prebiotics and symbiotics and all of these types of foods. And I have always been a proponent of food is first. So these are tough cases. I use medications, I use herbs, but many times we start with the diet. The first case, his SCD diet reversed the course of Crohn's for at least a year. So food, and then keep your eye on fecal microbiota transplant, because I think that's another future of medicine thing. The problem for me right now is, how do you find a good donor? Because they're all in the U.S., all eating a standard American diet filled with glyphosate and pesticides and all these things. So if I could go to Papua New Guinea and grab some indigenous person and take their stool, I might, think that would be a good option. But right now, I'm just not sure yet. How do we screen? Okay, so that's all I have. Thank you so much.
Thanks so much for watching, and for more great clips like this, please subscribe to our YouTube channel. I've created a special free video just for you. It's called the 5 Steps to Becoming a Leader in Your Wellness Community, and it'll give you some of the starting points on how to position yourself as the leader in your zip code of your health community. All you have to do is click on the link below.